Today we're going to talk about fundamentals of clinical trials, a topic which has wide applicability in our current medical environment. My name is David DeMets. I am professor of biostatistics in the Department of Biostatistics and Medical Informatics at the University of Wisconsin School of Medicine and Public Health. There's probably a couple of reasons why these fundamentals are important to learn. Most of us will be reading the medical literature throughout our careers, keeping up with the latest developments, and we need to learn to evaluate those articles critically as we try to understand what they have to say to us. In addition, some of us, including myself, are involved in the design and analysis of clinical trials, and these principles are also important. Fortunately, the same principles apply to reading the literature as well as to conducting trials and analyzing them. Today we're going to talk about a few topics, as I've listed here, the types of studies that one might be engaged in, what the basic question is that the study is trying to answer, what measurements one uses to assess that question, what population we need to study, what the experimental design needs to be that's appropriate for the question being answered, a need for monitoring the trial for safety and interim results for efficacy, and finally, some principles in the analysis of those studies. Each of these topics we could spend an hour or more, but today we only have time to touch each of them briefly to raise some of the fundamental principles. So I've listed here some types of clinical research that many of us will be involved with either as a reader or as a participant. The case report is a very important element in our clinical research portfolio. It usually is anecdotal. It usually alerts us to a potential problem that we may not have been aware of previously. A more common research tool is the observational study. It's a study where we observe a population in time and try to assess risks or associations. There are three classical such designs. One is the case control study, or retrospective. In this study, you examine patients who have a disease or an event and compare those patients to those who didn't have the event and try to ascertain what was there about them that was different, that might have put them at risk for this event. The cross-sectional design is one where you look at a cohort across time and try to understand the association between events that exist or have occurred with, again, the risk factors that you can measure. Here I've listed a couple of examples. One is a diabetic retinopathy study in western Wisconsin. Another is a ophthalmology study, observational study in Beaver Dam, Wisconsin. The prospective study, observational study, you measure a population or a cohort at one point in time and then follow them over subsequent years to understand risk factors that they had were predictive of events that took place later in time. The Framingham Heart Study is probably the most well-known of these type of observational studies, where we learned about the risks of diabetes and high blood pressure and high cholesterol and so forth on coronary heart disease. Any cross-sectional study, if there's enough time and money, can be also turned into a prospective study, and you can follow that cohort forward in time. But all these observational studies are trying to demonstrate associations between a set of risk factors, potential risk factors, and something that's going on or will go on. It's very difficult, however, from observational studies to argue and demonstrate cause and effect. If now, for example, we have a demonstrated association between, say, high blood pressure and coronary heart disease, we now have to figure out, suppose we modify the blood pressure. We then go into a third category or series of studies, which is the drug development process. We first have to figure out what pharmacological modification we can make that might lower blood pressure. And so we go into the laboratory and develop such drugs. Once we have those drugs, we then have to test them in humans, the first stage, and then if the drugs work as we had hoped they would do in lowering blood pressure, we go on to later phases, which we'll be talking about. Eventually, we have to test whether the drugs actually do what we hope to do in terms of their impact on the patient. So now we looked at a fourth type of experimental design, and we have three options. The historical control design, we compare what we're doing today in a population and with the results we had in a previous era, perhaps last year or the last decade. The concurrent control design is what we do in one setting, like in a hospital, with what goes on in another hospital or another setting. The patients are measured at the same point in time, but under different conditions. The trial or the experimental design that we're going to focus on the most, though, is the randomized clinical trial, and I'll demonstrate later why that's of interest. But in the experimental designs, we're trying to really here test cause and effect. If I modify a risk factor, do I get the clinical impact that I really want? Now, clinical trials, as we know them today, are not all that old. The earliest trials of the kind we talk about today really started in the late 1940s, early 1950s in the Medical Research Council of Great Britain. The tuberculosis trial of 1948 is probably considered to be the grandfather trial. It was randomized. It was studying streptomycin versus placebo in a tuberculosis population. And one of the pioneers of clinical trials, Bradford Hill, laid down many of the principles which we're going to talk about today. In the U.S., one of the earliest clinical trials that applied these principles was the Coronary Drug Project. I'll be talking about that later. So the message here is that the clinical trial itself is not so old, although the principles of clinical trials, experimental design, have been around for much longer. So I've already alluded to this, the types of trials we would conduct in man. There's the early phase, or sometimes called the phase 1. If it's a drug that we're studying, we have to first of all test it in humans at some point in time. And what we really want to do in the phase 1 design is understand what the acceptable range or the dose of the drug we can give safely within the context of the disease that we're investigating. So this is the first study and first series of studies, and we really want to find out what's the dose range. Once we understand the dose range, we really want to move on to the second phase and ask the question, does this treatment, this drug, this biologic, this device, modify the risk factors or the intermediate outcomes in a way that we anticipated? The doses and schedules may not always be optimum, but we're trying to understand if it's active. So once we understand the dose range, therapy actually is active, the last phase that's listed here is the comparative trial to understand if the new therapy actually brings about a change in the patient outcome that we desire. So we work through these phases in a sort of sequential, logical fashion, and hopefully we have a successful therapy at the end of all of this. In clinical trials, there's a whole series of ethical guidelines that we need to be conscious of. Much of this started following World War II with the Nuremberg trials and also subsequently the Nuremberg Code. This code developed a set of standards for judging physicians and scientists who had conducted experiments in concentration camp prisoners during World War II. But we have retained many of those principles and carry them with us today. The Helsinki Declaration of 1964 and many revisions since then are also a set of guidelines as to how we should conduct research. Federal governments, both here in the United States and elsewhere, have issued guidelines about how research is to be conducted within the country. Here, the Department of Health and Human Services has a set of guidelines which are quite lengthy and detailed. The FDA, the Food and Drug Administration in the United States, also has a set of guidelines of how trials are to be conducted if they are to be presented to them for approval of a product, whether it be a device, a biologic, or a drug. And also, many institutions have their own set of guidelines that are added to the international and federal guidelines. So we need to be conscious of these. These are not topics which we'll have time today to go into, but you need to be aware that there are such guidelines and be familiar with at least the basic principles of these guidelines. So why do we think about clinical trials at all? Well, first of all, we're trying to, medical research, understand and develop new therapies that are effective. The clinical trial is, we believe, the most definitive method of determining whether a treatment or an intervention is effective. Other designs that I listed have more potential biases. Bias is the enemy of the research that we're trying to conduct. By bias, we mean that one therapy, one intervention has an advantage over the other just because of the way we've conducted the research. Bias is sneaky and can be very powerful in affecting our results. Large numbers do not minimize or eliminate bias. So because the study is large doesn't mean we can understand that we have no bias. Second, we cannot determine on the basis of an uncontrolled observation, that is, an experiment with no control group, whether an intervention has made a difference or not because of these biases. So we believe that clinical trials are our best tool. An example of that, which you might be somewhat familiar with, is the area of hormone replacement therapy. The hypothesis was put forward that hormone replacement therapy reduced coronary heart disease. We already knew that it had an effect on osteoporosis, of course treating symptoms, postmenopausal symptoms, but there was supportive data about this coronary heart disease hypothesis. First of all, the hormone replacement therapy, estrogen, progestin, lowered lipid values. There were non-human primate studies which verified this. There was observational studies that said women on hormone replacement therapy had a lower incidence of coronary heart disease. So there's a lot of data, observational data, experimental laboratory data, that suggested that hormone replacement therapy would in fact reduce coronary heart disease. In fact, based on this observational data, the use of hormone replacement therapy from postmenopausal women became very popular. It was estimated that one-third of the women postmenopausal were using HRT. It was among the most prescribed drugs in the United States. Obviously, a lot of money was spent on these drugs, either the estrogen alone or the estrogen plus progestin, whichever was prescribed by the physician. So this was a very popular and a very expensive therapy that was being used on the theory that it would reduce coronary heart disease. Well, the Women's Health Initiative came along in the late 1990s and tested the hypothesis. In fact, it tested several hypotheses. It evaluated the use of hormone replacement therapy, it evaluated a low-fat diet, and evaluated calcium supplementation. So we have multiple outcomes for each of these treatments. In particular, for the use of hormone replacement therapy, we were interested, of course, whether it reduced coronary heart disease. That was our primary question. We also had a worry, perhaps, that it would have some impact on invasive breast cancer. We expected it to have an impact on fracture rates. And those who designed this trial came up with a global index, sort of putting all these pieces together to come up with a single outcome that sort of says, on the whole, is HRT better or not? Well, this was one of the largest trials ever conducted, so it's large. 300,000 women were screened into this trial. Of those who were screened, 18,000 provided consent, and there was two components, those which still had a hysterectomy and those who did not. For those who did not have a hysterectomy, still had their uterus intact, 16,608 patients were randomized, half to estrogen plus progestin, half to placebo. As the lower boxes indicate, the trial stopped in April of 2002. The number of deaths in each arm is about the same, 231 versus 218. However, if we examine the outcomes that we specified, we find some surprising results. First of all, in this graph, we have the incidence or the hazard of incidence of the coronary heart disease in the leftmost graph versus time. Each of those tick marks represent a 1 year of follow-up. So in the little legend, there is a HR, which stands for a hazard ratio of 1.29. That says that the individuals on hormone replacement therapy had a 29% increased risk over these 7 years of follow-up. And there's a confidence interval that's provided for that from 1.02 to 1.63. So it's even nominally significant. On the right-hand side, we have the same kind of a graph for invasive breast cancer. Here you will see that, as the worry was, that in fact HRT did increase the risk of breast cancer, in fact by 26%. The hazard ratio was 1.26. So we didn't get the result we expected, despite all the observational data and laboratory data, and in fact coronary heart disease risk was increased. Our worry about invasive breast cancer came to bear with an increase of 26%. If we look at the global index, which was putting all these pieces together, we see a 15% increase in the risk in the HRT arm, with a hazard ratio of 1.15. Interestingly enough, despite this increase in risk over the 7 years of follow-up, the risk of death is about the same in either arm, whether you're on estrogen placebo, or estrogen progestin, or the placebo arm. So this trial was stopped early because of the increased risk in coronary heart disease, contrary to the expectation of a benefit. So here's a classic example of where the observational data, large data, well-collected data, did not predict the ultimate clinical outcome when it was put to a randomized controlled study. So we now need to examine what's the question. In order to really design a trial, you need to specify what the question is you're trying to test. and must be specified in advance carefully. It's not okay to take a study and figure out what the question is after you've seen the data. We don't bet on a horse after the race has been run. Likewise, we can't develop the question after we've seen the data. So we insist that the question be specified in advance so that we can test that question without being influenced by the data that we might obtain. So we tend to categorize these questions into two groups at least, perhaps more. But at least we want a primary question, which is the most important central question. Ideally only one, although many trials have two or three. Stated in advance, as I've said. And the reason we like to have this primary question is it's the basis for the design of our study and the sample size and many other issues that we will be developing in the trial design. Of course, we never conduct a study, a randomized trial, to just answer a single question. We have lots of questions in mind, but we're going to put those into a special category, which we call secondary. They often are related to the primary. They may be confirmatory or supportive in some way. Again, we need to state these in advance, at least the key ones, and we cannot have an endless list of these. Otherwise, we run the risk of just finding things by chance alone. So we try to limit both primary and the secondary questions to a small number of the really important cases. Every study always has interest in special subpopulations or what we call subgroups. Because we have questions about the effect of the therapy in a subpopulation, such as if I'm studying lowering blood pressure, does the therapy work the same for men or women, for white or non-white, for those who have mild disease or severe disease, prior therapy, no prior therapy, and so forth. So we have lots of questions, but again, if we make this a very, very long list, we may find, again, results in a subgroup by chance alone. So again, we apply some rules. One, please tell us in advance which subgroups are key clinically that you would like to answer. Limit them in number because of the issue of a long list. You'll find things by chance. And by experience, I think we've all learned that you need to interpret subgroups always very cautiously. More in a qualitative sense, do the results seem to go in the same direction, or is there diversity across the different subgroups? We look for consistency. Consistency, I think, is the main thing you can get out of the subgroups that you can rely on. Sometimes we use subgroup questions to confirm a specific question, answer to a specific question that was generated in a previous trial, whether it's an age subgroup or other risk subgroup. We may use the subgroup data to generate a new hypothesis. After all, research is a sequential. It's a series of studies. Each study, hopefully, we learn more and get closer to the correct answers. And as I've indicated earlier, we really like to see if there's consistency across the subgroups and across the outcomes that we've specified, especially the primary outcomes. One of the really challenging areas in clinical trials is the assessment of adverse events. We believe that any intervention should do more benefit than harm, and we're always assessing the risk-benefit ratio. However, it's not always easy to specify in advance which of these variables will be the ones that we should focus on. The reason is we make many measurements, many clinical, many laboratory measurements, and because of the large number, some of them could be different by chance alone. So we don't really want to demonstrate an intervention is harmful, but we do have to assess a large portfolio. We may be fortunate in some cases to know that certain adverse events are something to focus on. For example, it may be that the therapy in the phase 1 or phase 2 studies showed some indication of an abnormal liver function test, or an impact on cardiac arrhythmia, for example. If that's the case, then we can specify those adverse events as the ones that we would place the highest priority on, and again, try our best to assess all the rest. But in either case, it's always a challenge, and especially in these days when we have had a lot of attention recently on adverse events, long-term adverse events in clinical studies. Well, if we've figured out what the question is, the next challenge is how are you going to assess the question? What measurement will you use to answer that? There are some characteristics of measurement that we really want to be sure we have, that's well-defined and stable. It's not probably a good idea to go into a trial with your primary question depending on some new recent development, high-tech outcome. because we don't know if it's well defined, if the technology is stable, and so forth. We also want to be sure that we can measure this outcome in all patients. If there are problems that some patients can't get measured because the measurement technique is too complicated, takes too much time, we may wind up with a bias. We for sure want to make sure that the outcome measurement, the response variable, in itself is an unbiased assessment, and that it can be reproduced. If we measure the patient on 2 consecutive occasions, we would expect to get the same answer. And finally, we want to make sure that the outcome is specific to the question that's being asked. Sometimes outcomes are very good outcomes, but they're sensitive to all kinds of things, not just the question we're trying to test. One of the controversies that's been around for quite a while and continues to be around is the use of surrogate response variables. By surrogate, I mean here a substitute, an alternative to the desired or the ideal clinical response. Examples of surrogates, for example, might be to measure the suppression of arrhythmias in a population at high risk for sudden death. Or in AIDS, we discussed the use of T4 cell counts in testing the effectiveness of new therapies, in contrast to measuring progression to AIDS or death. We often rely on surrogates, these intermediate substitutes, in the development process to explore the potential of a new therapy, but the challenge comes when we try to rely on these surrogates in the final exam, where we're trying to confirm the benefit and risk of this new therapy. I'll show you an example of why this has been so appealing and what the problem is. In this figure, we've demonstrated that a disease process modulated through a intermediate outcome, think of it as blood pressure or lipid values or arrhythmias or immune system measurements, and those affect a true clinical outcome: death, hospitalization, myocardial infarction, progression of the disease. With this simple mechanism, if we intervene in the disease process and modify the surrogate, this diagram suggests we, of course, for sure would modify the true clinical outcome. This concept was published in a paper by Tom Fleming and myself in 1996, and it was challenging the use of these surrogates as the final exam, final test of a new intervention. The reason for that challenge is there are many possible pathways that one can imagine. In this diagram, we've listed 4, A, B, C, and D. There are many others which you could think about. In scenario A, the disease, in fact, does modify the true clinical outcome, but it does so independent of modifying the surrogate, the intermediate outcome. So you could modify the surrogate quite well and have no effect on the true clinical outcome. Probably more realistically is scenario B, where the disease process, sure enough, is modulated through a surrogate or an intermediate outcome, but also has another pathway which does not depend on the surrogate at all. So one could be quite successful in modifying the surrogate and have perhaps some impact on the true clinical outcome, but in fact there are many other pathways which would overwhelm intervention effect. Scenarios C and D are others, such that you could have impacts on the outcome and not modify the surrogate at all. We've seen cases of that, and so forth. So there are many pathways, and just relying on the surrogate as the final exam has proven in many, many instances in many disease areas to have given us encouragement of a new therapy that ultimately failed when we gave it the final clinical test. One of the classic examples in cardiology is known as the cardiac arrhythmia suppression trial, otherwise summarized as CAST. The hypothesis was suppression of an arrhythmia following MI reduced the incidence of sudden death or total mortality. There was lots of data that suggested arrhythmias correlated with an increased incidence of sudden death. So the idea was that arrhythmia suppression was considered as a surrogate outcome. In fact, it became a practice to use proven interventions for reducing arrhythmias in patients who are at risk having arrhythmias. Well, the cardiac arrhythmia suppression trial was a trial that was designed, well designed. It was randomized, double-blind. We'll talk about those concepts. It would take place across many centers. It had a very elaborate monitoring plan. It had a significance level of 0.025, one-sided for benefit, and a 0.025 for harm. Although it was initially designed as a one-sided test for the benefit alone, it had the opportunity to examine harm at the 0.025 level as well. It had a run-in period where you had to have a arrhythmia suppression in order to qualify to be randomized to either the drug or the treatment arm. Well, surprisingly to most people, cardiologists especially, that the trial was stopped early for harm. Shown on this slide are results at an intermediate stage quite early in the trial, about 15% of the way, where both the number of sudden deaths and the total mortality greatly exceeded the number of deaths in the placebo arm. This was contrary to expectation. Based on prior data and observations, it might have been assumed to be the reverse, but in fact it was not. So this was an example of where the surrogate outcome led us down a pathway to believe that suppressing arrhythmias through a certain class of drugs was a good thing to do, when in fact it was a harmful thing to do. It's always a challenge to figure out what population one wants to study. We need to define the population by something we call eligibility criteria, which is defined in advance, and these criteria will characterize the population that we're going to study. And it's very important to characterize that population because it will have implications on the impact results and also if you want to repeat the study. Most studies are not conducted on a random sample. They are not typically a random sample, but a special sample. But just because the sample is not representative of the total population does not mean you have a biased trial. You have to keep in mind that just because the sample is biased by high risk, low risk, that it doesn't mean that the results should be biased. What do I mean by that? Well, we have a population in mind, a patient population. That's the patients we're treating out there. We define a study with a protocol with specified entry criteria, and that will eliminate patients who probably, for one reason or another, should not be in the study. They're at low risk to higher risk. They have conflicts with the therapy that's being tested. And so we define entry criteria that gets the population we think would be proper, appropriate for this therapy. Then we go out and conduct a study, and patients show up, participants show up, consent, volunteer, and get on the study. It's unlikely, we're pretty sure, that sample of patients is a random sample of the population that we even defined in the protocol. These are the patients who volunteered. From this special population that we're studying, sample A, we observe results. And if we've done our work properly, we'll have a fair, unbiased test of the observations on that study sample A, the ones who volunteered. But now we want to do more than that. We want not only to make inferences about people like the ones who showed up in our study, but we'd like to make inferences about the population that we define in our protocol. But that's a leap. It means that we believe that whatever we observed on the sample that we studied is also applicable to the population we had in mind. And then, of course, ideally we'd like to make inferences about the population that shows up in your clinic. But each of these steps, going from A to B to C, is stepping further out and an inference that we have less reasons to believe or to be able to defend. Whenever one is defining eligibility criteria, the population we're going to consider entering into our study, we have two conflicting forces. Should we have a very homogeneous, tightly defined population, or one which is very broad, heterogeneous? One is well defined, one is less well defined. If we want a homogeneous population, very tightly defined, it's probably that we believe we know something about the mechanism of action. We know exactly in whom the study would work in some population. However, often we don't know as much about the mechanism, and so maybe we would like to understand in which population it does work better than the others, and so we'd have a very broad, heterogeneous population. The tighter we define the entry criteria, eligibility criteria, the harder it is to recruit. If it's broad, of course, it's easier. But if you have a very homogeneous population and the therapy only works unknown to us, but works in one subgroup, then we will dilute the results. So there are these conflicting forces between a very tightly defined population as one which is broader. And we need to assess which way we should go depending on what we know about the therapy and the population of the disease we're engaging. One of the challenges, in fact the most difficult challenge probably in any clinical trial, is recruitment of subjects, participants into the study. It's always more difficult than anticipated, even for investigators who are quite experienced. One principle that really is important to keep in mind is that the yield will not be 100%. If you see 100 patients in your clinic that have a particular disease, breast cancer, heart failure, you will not get all 100 into your study, because sometimes the eligibility criteria, whether it's age, prior history, prior treatment, will exclude those patients as not being desirable in this particular study. There'll be exclusion criteria which may kick out people who may not be able to tolerate the therapy. Sometimes the physician does not think that it's the right study for their patient, or the patient may not think it's the right study for them. So the rule of thumb is that we believe that many good trials, will get a 10 to 15% yield of those that are screened that actually get randomized. 20% would be excellent. So that's really an important lesson to learn as you engage in studies. The second point is that recruitment into studies is a team effort. It cannot rely just on a single individual. It, of course, relies on the health professional, the physician, or the physician's assistant, the nursing, data managers, coordinators, and so forth. Working as a team, they can be effective. But if this team is not put together properly, it may not be such a successful recruitment effort. And finally, I've already addressed this a little bit, that there is a healthy screening effect. Those who get into the trial typically have a lower risk than you expect because of all the winnowing and filtering that goes on in the recruitment process. Well, thank you for listening to the first issues we've raised here in the fundamentals of clinical trials. In part 2, we are going to consider some more details of design and aspects of conduct of studies.